This
extradural
conference will
abscess
now
that
be
occurs to
recorded.
erosion of the tegmen. So tegmen getting eroded. So this is the bone. So you have the bone outer, you have the periosteum, and then you have the bone, then you have the dura, then you have the subdural space, and then you have the pia and the arachnoid, and then you have the subarachnoid space, and then you have the brain parenchyma. So many layers are there. So the disease has to reach all these layers to reach the brain. Now, just continuing our now, when the brain abscess develops, no, it doesn't develop in a day. It takes its own time to form. So these can be broadly categorically divided into 4 stages. One is the stage of early cerebritis, that is day 1 to day 3. Then number 2 is the stage of late cerebritis, day 4 to day 11. Then stage of early capsule formation, that is day 11 to 13, and late capsule formation. So these 4 stages are there. And what happens in stage of early cerebritis, where there is inflammation. So there is inflammation in the brain, and you can see that the necrosis of the brain is just starting, and surrounding the inflammation you have the polymorphonuclear cells. So the necrosis of the brain is just about starting. Then the second stage, it goes after 3 days, that is the stage of late cerebritis. So here what happens, now what the brain undergoes liquefactive necrosis, and surrounding the brain there is an area of inflammation, edema, and also polymorphonuclear cells. So here the abscess is formed and it starts to expand. The abscess slowly starts to expand, and then you have the stage of early capsule formation and the stage of late capsule formation. So by 2 weeks time, you have a definite capsule. And if you see the brain abscess, it has two sides. One is the cortical side, and another is the ventricular side. The cortical side, the capsule is very well formed, and the ventricular side, the capsule is ill formed. So this what happens ki whenever a brain abscess ruptures, no, it ruptures into the ventricular system. So it ruptures into the ventricular system. Now these are the 4 stages, and then what happens ki the brain abscess has a triad. One is the high grade fever, and then you have focal neurological deficit, and then you have vomiting. So they're characterized by 3 things: high grade fever, and so headache, high grade fever, and focal neurological deficit. So depending on, now if it is in the temporal lobe, the neurological symptoms will be different. If it is in the cerebellar, the neurological symptoms will be different. So if the brain abscess results in a cerebellar abscess, then obviously you will have the cerebellar symptoms like ataxia. Patient may not will have a broad base gait, dysdiadochokinesia, past pointing. All these cerebellar features will be there, vertigo and all. If it develops in the temporal lobe, then patient will have homonymous hemianopia, and they have nominal aphasia. Means they cannot name a object, but they can tell how the object is used, for what purpose it is used, but they cannot name it. So that is the feature of temporal lobe abscess. So the frontal lobe abscess usually results as a sequelae of or a complication of sinusitis, whereas the temporal lobe abscess occurs as a complication of chronic suppurative otitis media. So among the two, the ASOM and the CSOM, the brain abscess is usually seen as a complication of CSOM rather than ASOM, and CSOM, and that too particularly as a complication of cholesterol. So once you suspect a patient, and then what happens ki, as the abscess keeps on growing, so now once the capsule has formed, no, this formation of capsule is also dictated by two three factors: oxygen concentration, then the type of organism, and the immunity of the patient. So these three factors determine the capsule formation. If the immunity is less, organism is say very aggressive, then what happens? The capsule formation is delayed, and lot of brain tissue is lost. And if the oxygen tension is also low, then lot of brain tissue undergoes liquefactive necrosis. And usually from the day of inoculation to the day of capsule formation is roughly around 2 weeks time. Is roughly around 2 weeks time. So now a patient who has come to you either with some focal neurological deficit or with the triad of say headache, high grade fever and focal neurological deficit. So you suspect it as a brain abscess or maybe a meningitis or some intracranial complication. So in this scenario, the investigation of choice will be to go for a CT scan, a contrast CT. So a contrast CT scan will give you a ring sign in case of brain abscess. And because the liquefaction is there, no, the dye won't be taken up. So that will appear as a hypotense lesion, but the surrounding brain parenchyma or inflamed brain parenchyma or edematous brain tissue will take up the dye and will be well demarcated and will appear as a ring. So that is called as a ring sign. So ring sign is classically seen in case of a established brain abscess. And then treatment, obviously you need your neurosurgical colleague to help you out. You need burr hole to drain the abscess, and then you can also simultaneously, or after the patient condition stabilizes, you take care of the mastoid. So if it is secondary to cholesteatoma, then definitely nothing less than a modified radical, or you can also go ahead and do a radical mastoidectomy because because of this thing. But sometimes what happens, but make sure you don't leave behind any disease, because if you leave behind any disease, then there might be recurrence of the brain abscess. So very important, the organisms, the presentation, uh, and when the abscess starts to expand, you will have features of raised intracranial tension like severe headache, vomiting, projectile vomiting will be there, and there will be papilledema, and patient may become delirious with a decreasing loss of consciousness, intense headache, and if you examine, sometimes also you may, if you examine with a ophthalmoscope, then you will clearly make out the papilledema, and there will be blurring of the optic disc. So very important, it should be diagnosed as early as possible, and there is a dictum: abscess anywhere in the body should be drained first, then whatever antibiotics you want to give, you can. So here you give a high dose of antibiotics, like you can go with a multiple regimen, like having a good gram positive, gram negative anaerobic coverage. So anaerobic coverage is taken care of by metronidazole or tinidazole, and then gram negative coverage, you have a third generation cephalosporins. So third generation cephalosporins like ceftriaxone, the dose is much higher, almost double the conventional dose is required. And then after drainage of abscess, the patient condition improves drastically. The next is the extradural abscess. This is collection of pus between the bone and dura. So frequently coexist with sinus thrombophlebitis and precedes the brain abscess. So the overlying dural bone can be destroyed by hyperemic decalcification in acute otitis media and bioenzymatic activity in case of a cholesteatoma. And then pus collects in the epidural space. Treatment is antibiotic therapy and do a proper mastoidectomy. If it is secondary to AOM, do a good cortical mastoidectomy, and with you just have to thin out the tegment plate and just let the once the tegment plate gets thinned out, automatically the pus will start to come out because it is under a little bit of pressure. And then once the pus is drained out, you can rinse the area with antibiotic solution and remove any granulation tissue or any dead bone in that area. And also you can also repair the defect using a bone, either a bone wax, or even you can use cartilage also. The subdural abscess or empyema, it is a very serious condition and has a very high mortality, and it is one of the rarest complication, intracranial complication. So subdural abscess means just below the dura and between the dura and the brain, between the dura and the subarachnoid space. So a collection, this is a potential space, and the subdural space is divided into different compartments by the foramen magnum, by the tentorium cerebelli, falx cerebri, and the base of the brain. So these four structures, they divide the subdural space into multiple compartments. And what happens when the pus collects or anything collects, no, it collects, and then the pressure is directly transmitted onto the brain tissue. So very important, and it has a very rapid course, and patient can be well off in 1 minute and can deteriorate in the another. Very important. And the spread of, again, involvement of subdural space can occur in three ways. One is by thrombophlebitis, another is by direct erosion of the tegment plate, then erosion of the dura, and then the infection going into the subdural space. Or in other way around, if there is a brain abscess and the capsule ruptures into the subdural space, leading to a subdural abscess. So three routes. One is via the tegment plate, erosion of tegment plate, erosion of dura, then goes to subdural space, venous thrombophlebitis is the second route, and third is from inside, a brain abscess rupturing into the subdural space. So it's a neurosurgical emergency. So immediately you have to diagnose. So how to diagnose? A sudden abrupt onset of headache and with a rapid onset of disease, rapid onset of signs and symptoms like intense headache, nausea, vomiting, focal neurological deficits occurring within a span of few hours indicates a subdural abscess. So immediately you should get a MRI done, which is the investigation of choice. Get a MRI done. The MRI, the advantage of MRI is it differentiates between the subdural space and the subarachnoid space and the extradural space. And number one. Number two is the contrast produced by bone, by the CSF, and by the meninge, by the brain parenchyma. All are different. So you can easily make out which is what. And there are no artifacts. Bony artifacts are not seen in MRI. And MRI also can qualify when tell you whether the subdural abscess is a sterile one, or has blood in it, or has pus in it. So that also you can know by MRI. So very important. You should do a MRI, and drainage should be done. Here in this case, lumbar puncture is contraindicated to prevent herniation of the cerebellar tonsils. So you have to drain it immediately, and high dose of intravenous antibiotics should be given. And mastectomy if it is through the first route, that is uh, erosion of the tegmen plate and erosion of the dura. And in that condition, you have to do a very good mastectomy, remove all the disease process, and make sure the whatever infections are there is nicely drained out, and then you can cover that defect. Uh, then this I have told you. Now coming to meningitis. So meningitis is now, you can say, the most important or most common intracranial complication. So inflammation of leptomeninges, that is pia and arachnoid, and CSF of the subarachnoid space, which surrounds the brain, spinal cord, and optic nerve. So this is like a general. It can divide into two parts. Either it may be a localized meningitis, or it may be a generalized meningitis. So this definition is a definition of generalized meningitis. So localized meningitis can result from a focal area of infection is in touch with the para-arachnoid layer or is in contact with the CSF of subarachnoid space. So mortality rate was very high in the pre-antibiotic era, where the recovery rate was just 10%. But now it is seen that around 80, more than 80% patient recover. But thanks to the good antibiotics we have in this time. So again, the microbiology, the meningitis gram-positive organism mostly is pneumococcus, Moraxella catarrhalis, and Haemophilus influenza. So these three are very common organism, gram-positive, and the gram-positive organisms are usually secondary to ASY. But you can also get gram-negative organism, as well as you can also get a polymicrobial flora. So it depends on say if it is a CSOM, then you may have a gram-negative organism. You may also get anaerobic organism, or you may also get a polymicrobial flora. Now, pathways of spread through preformed pathways like a patent petrosquamous suture line, or the perineural spaces to the internal auditory canal, or can also this what the perineural spaces of the internal auditory canal via the labyrinth through round and oval windows. So infection of the ear, then of the middle ear, and then the infection spreads through the round window and oval windows to the labyrinth, and from labyrinth goes to the internal auditory canal, or from labyrinth goes to the endolymphatic sac. From there it goes to the meninges. So the route taken by the endolymphatic via the endolymphatic sac is rare. or maybe a result of retrograde venous thrombophlebitis, or maybe direct erosion of bone as a result of mastoiditis or petrositis. So maybe mastoiditis or petrositis uh, uh, can also lead to meningitis. So now coming to the clinical scenario of meningitis, uh, this patient usually presents to they start off with intense headache, and then you have fever, high grade fever, along with vomitings. As the disease progress, no, the headache, the fever and vomiting gets worse day by day, and there is also other symptoms like patient may have photophobia, may also develop blurring of vision, and all those things. So, but the most common thing which patient develops in the initial part of the when the meningitis is just starting is headache, fever, and vomitings. So these three things are there, and there is also feature of raised intracranial tension, and then slowly the patient develops neck rigidity. So if you ask the patient to touch the chin by flexing the head, the patient cannot do it. And when you try to touch or you try to gently push the head from behind and try to make the chin touch the neck, there is high resistance. This resistance is due to spasm of the paraspinal muscles, not allowing the patient to touch the chin. So there are two signs. One is the Karnik signs and the Brudzinski sign. So the Brudzinski sign is you make the patient lie down, and the moment you try to flex the neck to the chin, there is folding of the legs. So folding of the legs. And the Karnik sign is when you ask the patient, you make the patient lie down and flex the hip joint so that the knees are touching, the thigh is touching the abdomen, and then try to extend the leg. So you cannot extend. And the moment you do so, patient will experience pain in the spinal canal region, so or in the neck region. These are the two signs, that is the Karnik sign and the Brudzinski sign. So patient coming to you with history of fever, vomitings, and severe headache, and getting neck rigidity, always make sure the diagnosis is meningitis, unless and until it is ruled out. So how to rule it out? There are 2 to 3 ways. You can do a contrast MRI, which is very, very good, and also you can do a CSF study. So you take the CSF, you draw the CSF, and send it for. And when you draw the CSF, no, the CSF looks yellow in color. That is called as xanthochromia. So it looks yellow in color, and when you send it for the CSF for culture, or you send it for the gram staining, you send it for the biochemical study. So three things we do: we do the culture, we do a gram stain, and we do a biochemical study, and we do a cell count. So what happens here? The CSF normally is watery and clear. It's very clear and watery. But here no, because the cells is so high, it appears turbid and yellow in color. That's called xanthochromia. And then when you do a count, the counts are very high. And usually, mostly it is polymorphonuclear cells. That is, the neutrophils are high. The neutrophil count is very high, the cell count is high, and then when you do the biochemical test, the protein is high, the sugar is low, and the chloride remains okay. So high protein and low sugar, and then along with xanthochromia, reaches the diagnosis of meningitis. So MRI you can do with contrast. Definitely, the inflamed meninges will take it up. CT scan also plays has a role, particularly if the cause is due to retrograde venous thrombophlebitis, due to a granulation tissue or osteitis, or direct erosion of the bone. So in these conditions, uh, definitely CT will role in the sense that it will give you the anatomy of the bone. So for that point, but among CT and MRI, obviously MRI is superior uh, because it gives the adjacent brain, the status of the brain and brain parenchyma also. Now, so patient has you have diagnosed a case, and when you've done the MRI, you have done the biochemical study. Now the report has come. So gram staining will show whether it's a gram positive or gram negative, and also you can do a culture, so that will also. But before the culture report usually takes 3 days time. You don't have that much, neither do the patient. So you always, once you draw the sample, no, you put the patient on a broad spectrum antibiotics. So here for meningitis, the ideal antibiotic which is given is a third generation cephalosporin. Third generation cephalosporin has good gram positive as well as gram negative coverage. So in that condition, you start with third generation cephalosporin, and the dose is double the conventional dose. Now, one question you may ask: why third generation cephalosporin is used? One most important thing is they are non-toxic drugs. Number two is they cross the blood-brain barrier. So they cross the blood-brain barrier. Number three, they are bactericidal drugs. So they kill the bacteria. They don't. They are not bacteriostatic. They are bactericidal. They kill the bacteria. And number five is they inhibit the beta lactamase. So the beta lactamase, which resists the antibiotic, these third generation cephalosporin inhibit the beta lactamase, so thereby making the bacteria more sensitive. So these are the four reasons why we prefer to use a third generation cephalosporin. The role of steroid is controversial, but what happens here is when you give a high dose of antibiotic from the beginning, there is severe bacteriolysis. So when the bacteriolysis occurs, no, the bacteria they release the toxins into the circulation. So they release the toxins. These toxins, when they are absorbed, patient will have lot of sequelae, permanent sequelae, like a sensory neural hearing loss. So to prevent that, you give steroids. So the most likely steroid used is a dexamethasone, and the steroid is given concurrently with the IV antibiotics. But there is a condition where you can give only if it is secondary to ASOM, then you can go for a steroid. If it is secondary to CSOM and all, or if it is secondary to a trauma. But here another route we have not mentioned is a trauma, a fracture of temporal bone with rupture of. So in this condition, you need not give steroid, but you put the patient on high dose of IV antibiotics, and they respond. So what is the treatment? If it is a case of ASOM and the patient still has a bulge drum, and then already he or she has gone to meningitis, the best thing is you do a grommet. You give a radial incision and insert a grommet. If it is due to a secondary to mastoiditis, you do a very nice simple mastodectomy, and then remove all the diseased air cells or exonerate all the diseased hair cells, and that is and establish the patency between the mastoid and the medial layer. The results are good. And if it is due to a cholesteatoma, then obviously you have to go for a canal wall down modified radical mastectomy. So third generation, I've told you, drug of choice, intravenously for 7 to 10 days, then change according to culture, and surgery, I told you, cortical or MRM, depending on the situation. Now, another thing I'll just tell you, it is not, is known as the otitic hydrocephalus or benign intracranial tension. So, otitic hydrocephalus is a very what you say an interesting complication, and this complication no uh, occurs secondary to lateral sinus thrombophlebitis. So how this hydrocephalus develops, there are 2 to 3 postulates. One, the most accepted one is from the sigmoid sinus thrombosis, there is a retrograde extension of thrombus into the superior sagittal sinus. And from the superior sagittal sinus, there occurs a blockage of the arachnoid villi, and these arachnoid villi are responsible for absorption of CSF. So once the arachnoid villi are blocked, the absorption of CSF cannot occur, and then thereby leads to overproduction of means excess of CSF, because you know that the CSF production absorption are going on simultaneously. Now, if absorption is halted, production is going on, and obviously the CSF volume will increase over time. The second thing is CSF overproduction itself may be secondary to inflammation. And the third thing is due to occlusion of the sigmoid sinus, the venous drainage is hampered. So this venous hampering of venous drainage can lead to development of otitic hydrocephalus. The fourth one is, they say, is that is due to cerebral edema. So cerebral edema leads to development of otitic hydrocephalus. Now, diagnosis, how to make the case of otitic hydrocephalus is, patient will have features of raised intracranial tension, like patient will have headache, patient will have vomiting, but there will be nothing in the CSF. If you do the CSF study, it is absolutely normal. So then you establish the diagnosis of otitic hydrocephalus. So there are features of raised intracranial pressure, but in CSF you are not getting anything. When you do a fundoscopy examination, very clear-cut papilledema, you see blurring of the optic disc. All those things are there. And when you do a MRI, the ventricle size is absolutely normal. The size of the ventricle is absolutely normal. So these all things they join together to help you establish the diagnosis of otitic hydrocephalus. So MRI should be done, which shows that the ventricles are normal in size, and along with that, there is clinical feature of raised intracranial pressure. And if it is not relieved and left as such, then these can lead to, and also patient will develop diplopia, due to so this group of patients will develop also diplopia due to 16 or palsy, and then they will also, if they are not treated in time, a patient can land up with optic atrophy and blindness because of the raised pressure. Because of the raised pressure, these patients can land up with uh, optic atrophy and blindness. So you have to be very careful, and you have to there are features of raised intracranial pressure, but the CSF finding is absolutely normal. So this indicates or clinches the diagnosis in favor of diabetic hydrocephalus. Now treatment part is divided into medical and medical treatment, loop diuretics, or you can even give acetazolamide, which decreases the production of CSF. You can give mannitol, 20% to reduce the edema of the brain, and also you can give steroids, so to reduce the edema of the brain. So these are the medical treatment. The surgical part is the shunt operation. You do a ventriculoperitoneal shunt or a ventriculopleural shunt, or a ventriculopericardial shunt. So whatever shunt operation should be done to drain the excessive CSF, or if it is secondary to sigmoid sinus thrombophlebitis, you have to relieve the obstruction so that there will be again proper venous drainage through the diseased sigmoid sinus. That is called as decompression of the sigmoid sinus. So this finishes your complications of CSOM. Any doubt? Any doubt? Please tell, or you can chat also. Please enter your message if you have any doubt. Hello. 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 Am I audible?
Yes, sir.
Any doubt?
Yes, sir.
Ask. What is your doubt?
No, sir.
Huh? You put it. You text it on the chat if you have any doubt.
No, sir.
No doubt. Okay, so this completes your CSOM and extra and intracranial complications. So next class I'll be taking up some new chapter, like might be a fracture temporal bone or something. I will see. Uh, just hold on till I take your attendance. Okay. Thank you.